All right, today's lab is on page 26, looking at the respiratory system. And in objective number 1, we're going to start with the upper respiratory system. So when some people go into the doctor and say they have a cold, the doctor can say, it's an upper respiratory infection or a lower respiratory infection. So the upper respiratory are just including the nasal passages, the throat, not so much down in the lower airways. So we're going to focus at the beginning of the respiratory system and work our way down. So this is a sagittal model. We're just looking at one side of the head. Air enters in through the nose. So the nostrils, the fancy name for the nostrils, are the external nares. External nares is just another name for the nostrils. So this opening here. And then this whole space here where the air can flow around in kind of a turbulent pattern is called the nasal cavity. So what divides the nasal cavity from one side to the other, because we have two external nares, is the nasal septum. So the nasal septum is simply that bone that is in between the two nostrils. So you would only see that in a front view of the head, so it's not shown in this model. But if we looked at, for example, the vomer, if you remember the vomer bone that went inside the nasal cavity and kind of went up at an angle, and then the ethmoid bone is on the back of that wall that separates the two nasal cavities. That's the nasal septum, and there's some cartilage in front of that. So not really shown in this side view, but just the wall that separates the two halves of the nasal cavity. So then if we look, we have the nasal conchae, and the conchae are just, if you remember from when we studied the skull, they're those curled bones on the lateral walls of the nasal cavity. So we can see them here. These are the conchae. So there's a kind of a flap of bone that extends away from the wall, and it's covered with a mucous membrane. So as air flows into the nose, it kind of swirls around because of these nasal conchae causes the air to become more turbulent in there. And as a result of that, any debris that's in the air gets stuck against the sticky mucous membrane and doesn't continue on down into our lungs. So it's kind of a protective mechanism to provide more turbulence inside the nasal cavity. So again, these are the nasal conchae. So there's a CH, hard CH in the second part of that word. Then the nasal cavity narrows toward the back here. So this narrowing here at the back of the nasal cavity is called the choanne. So there's another name. There's the conchae that has the CH, and then there's the choanne at the back of the nasal cavity. So we call these the internal nares because it's just a passageway for air, but it's inside, deep inside the nasal cavity, so it's internal, where these are the nostrils leading to the outside are the external nares. So internal nares or choanne, we call those. Then what divides the nasal cavity from the oral cavity down below, so here's the muscular tongue, this whole structure here, so here's the oral cavity. There's a bone that separates the nasal cavity from the oral cavity, and that bone is called the hard palate. You can feel that with your tongue. Your teeth come down off of the hard palate. And when people are born with what's called a cleft palate, babies sometimes are born and that palate doesn't completely meet in the center, and their nasal cavity is open to their oral cavity. And sometimes the teeth don't form in the middle, and you'll see a big separation there. Multiple surgeries are required to repair that. Lucky if they're born here in a developing country, or a well-developed country where we have access to good, oral surgery, they can get that repaired. But sometimes in less developed countries, those children live a whole life with a cleft palate and never are able to eat or drink properly because the oral cavity and the nasal cavity are connected. So that's the hard palate, and then if we follow that bony piece back, it ends in the soft palate. So if you reach back with your tongue, you can feel in the back of your throat where it gets kind of squishy back there. That's the soft palate. And then the soft palate ends with a flap of tissue here, which is right at the end here, the end of the soft palate, and this is called the uvula. And that's the little punching bag that hangs down in the back of your throat. And there's a lot of sensory receptors on the end of that. So if food or your finger touches that, it initiates a gagging reflex, which prevents food from entering into the throat without our permission, essentially. So there's a physical, voluntary aspect of swallowing that we, the uvula raises up and allows food to pass through during the voluntary swallowing process. But if it's involuntary and food gets back there, then we have that gag reflex. So it serves an important function. Sometimes it gets really swollen when someone has an upper respiratory infection, really bad sore throat. You look back there and it looks terrible. I look back in people's throats. During this actual lab, people will be sick this time of year and say, oh, I have strep throat right now. We'll all look in the back of their throat and see these huge tonsils and swollen uvula. Really, people come to class, in a lot of pain with those infections. But sometimes that needs to be removed in people that snore, because that's what you hear rattling in the back of people's throat when they snore. And that can cause, contribute to sleep apnea when the muscles of the throat relax when someone's sleeping and laying flat on their back, especially if they're overweight. Obesity is a strong factor in people with sleep apnea and snoring because of all the extra fat around the throat. So sometimes losing weight can reduce or even eliminate sleep apnea, but not always. There are, thin people that also have sleep apnea. So this, it's not just specific to people that are overweight, but that is a big risk factor. So that's the uvula. So when we swallow, the uvula will push backwards and close off the nasal cavity so we don't have food or liquid going up into the nasal cavity when we eat. So it plays an important role in closing off that passageway when we swallow. So there's different regions of the throat. The throat is called the pharynx, and it's YNX. It's not NYX. Sometimes I hear people mispronounce it and call it the pharynx. It's not nix, it's YNX. It's inks, like the lynx cat, right? The cat with the short tail. So it's called the pharynx. And the pharynx starts at the top of the nasal cavity and goes all the way down to where the two passageways divide, where we have the esophagus here and we have the larynx and trachea down below. So where it's one common passageway for air and food, except for we don't see food up here in the nasal cavity, nasal pharynx. But this common passageway is called the pharynx. So we divide it into three major regions. So from the top of the nasal cavity here, at the top of the internal choanine, or internal nares, the choanine, down to the uvula, this region here we call the nasopharynx. So just know the boundaries to help you determine what's nasal, what's oral, what's laryngeal. So the tip of the uvula is the bottom of the nasopharynx. So then we have the oral pharynx, and that's where food enters. So from the tip of the uvula to this flap of tissue here, which we're going to talk about, is called the epiglottis. So from the tip of the uvula to the tip of the epiglottis, this region here is the oral pharynx. So that's the oral pharynx. And then from the tip of the epiglottis down to where the esophagus begins, so here's the esophagus, we can see there's two passageways, so this is where this pharynx divides. Air goes this way, food goes this way. So from the tip of the epiglottis to the beginning of the esophagus, this region here is the laryngopharynx. So there's a couple of structures to know inside the nasopharynx and the oral pharynx. So we'll go back up to the nasopharynx, which starts here and comes all the way down. We have a cluster of immune tissue, lymph tissue. And this is one of our lymph nodes. This is called the adenoids. Another name for those are the pharyngeal tonsils. The pharyngeal tonsils. So it's this cluster of kind of cottage cheese looking texture material up in the nasopharynx. So that's the adenoids or pharyngeal tonsils. So it's in the back wall of the nasopharynx. Then we have the eustachian tube or the auditory tube. If you remember when we studied the ear, from the middle ear, there was that tube that went from the middle ear, from that tympanic cavity down into the nasal cavity. That's what this is here. This hole right here is the end of a passageway that connects to the middle ear. And that every time you swallow, that clicking sound you feel in your ears, that's the auditory tube or the eustachian tube that's equalizing pressure between the middle ear and the back of your nasal cavity. So that's the eustachian tube or auditory tube opening. So it's right here. So when a person has a cold, like a 2-year-old has a kind of a snotty upper respiratory infection, a lot of mucus in there, that infection can creep its way up into the eustachian tube and infect the middle ear. So a classic symptom of a kid with an ear infection, because I've had a number of them, a number of kids and ear infections, is crying, waking up crying at night, because when a child lays flat in their crib or their bed, that pressure builds up in the middle ear and then they wake up in pain. So when you have a child waking up that normally sleeps through the night and they're waking up crying and they can't tell you why, probably pain in the middle ear. So the best treatment, what I've done, a little bit of Tylenol or ibuprofen, depending on their age, put them back to bed, get through the night, right? Because if you go to the ER with an ear infection, you are bottom of the list to be seen by that doctor, because that is not a life-threatening illness. So you'll sit there for 4 or 5 hours maybe. It's better to wait till the morning, call the pediatrician, bring the child in, on a regular appointment and have them seen there. But that nighttime awakening, and a cold that never resolves. When you have a child with a cold that drags on for 2-3 weeks and they've got snotty drainage and just constantly snotty, that's another sign of an ear infection in a small child. Not always, but with my kids, it was classic. When those head colds should go away within a week, at least the snotty, drainy part. And if it doesn't, that's often a sign of an ear infection. Okay, so moving down then, the oropharynx we said was between the epiglottis and the tip of the uvula to the tip of the epiglottis. So there's another pair of lymph nodes on the lateral walls of the throat. So we're talking left and right sides of the throat, just below the uvula. So we can see one embedded here, and this is one of the palatine tonsils. So these are the true tonsils that we see that are swollen when we have a upper respiratory infection, and these are the ones that have to get removed sometimes, right? For people that have chronically enlarged tonsils, what happens is these clusters of immune lymphatic tissue get chronically infected, and instead of filtering our blood and clearing infection, they become a source of infection because the bacteria never really go away. We treat them with antibiotics, but we don't kill them all completely, and pretty soon they're sick again. So sometimes it's the lesser of two evils, and it's best just to remove those. So some people have the palatine tonsils removed as well as the adenoids. And sometimes it helps with sleep. People have trouble sleeping when they have a lot of swelling in the airways, so it might be better just to remove them. And then the lingual tonsils are underneath the tongue. So here's the tongue, here's the lingual tonsils, this little cluster of, again, it has kind of a cottage cheese appearance in the cadaver, and that's the lingual tonsils underneath the tongue. So linguistics is the study of speech. So lingual refers to speech or the tongue. And then we already talked about the laryngopharynx is just from the tip of this flap of cartilage, the epiglottis, down to the start of the esophagus. So from here to here, we said was the laryngopharynx. So now we get to the lower respiratory system. Got a couple of structures here. It starts here with the larynx. So here's the voice box, that little, especially here, this is that piece that kind of sticks out, called the Adam's apple. Women most commonly do not have a visible Adam's apple externally. Some do, but most do not. It's more of a male characteristic because of the influence of testosterone. Testosterone causes an increase in the growth of cartilages. So men tend to have a visible Adam's apple. They tend to have larger ears, larger nose, just because the influence of testosterone. And because of that larger larynx, the voice drops. So you always know when boys are entering puberty, because of the increase in testosterone, you see the increase in the size of the larynx, and then that changes the space inside that, between those vocal cords, and the sound of the voice starts to drop. So right here are the vocal cords, these two kind of ridges of tissue here, those are the vocal cords. And we have a better view of these in the next model I'm going to show, but I'm going to show them on this model first, and then we'll look at it in the other model. So this is the vocal cords, or vocal folds is another name for it. And the larynx, like I said, is just this whole space here. But this is our larynx model here. So there's a bone at the top of the larynx that the muscles of the tongue attach to. And on our skeleton, it's usually broken off. But this is called the hyoid bone. It's a horseshoe-shaped bone at the top of the larynx. So that's a picture of it there. And then on this model, this bone here is the hyoid bone. It's at the top of the larynx. So look for that white structure. And then this whole thing here is the larynx. But the larynx is made up of two different cartilages. There's the thyroid cartilage and the cricoid cartilage. The thyroid cartilage is shown in these two big plates of cartilage here that has the number 2 on it. So each of these blue large pieces of cartilage are part of the larynx, and that's the thyroid cartilage. So that's the larger piece that you can feel when you look for your larynx on the front of your throat. And then below that is the cricoid cartilage. It's covered in muscle on this side, but you can see how it wraps around there. That's the cricoid cartilage. Kind of looks like a ring. It's thicker on the back side and a little thinner on the front. That's the cricoid cartilage. And then the epiglottis, if we go back to this model here, the epiglottis is this flap of cartilage that covers the passageway into the larynx. So here's the inside of the larynx. This flap of tissue here covers that. So we've got this so we have this model here. We can see how this flap tissue comes down. Kind of looks like a tongue, but that's the epiglottis. You can see how it moves. And if I look down in between, down in the center of this, there's two flaps of tissue in there. They're white. That's the larynx. Or not the larynx, that's the vocal folds. And the space between those vocal folds is the glottis. In this model here, so this is the epiglottis, this flappy tissue that covers the larynx here. This is the hyoid bone. And down here there's two little springs in this older model of the larynx, and the springs represent the vocal folds. And the space between the springs would be the glottis. Yeah, the glottis. So the glottis is the space between the vocal folds. We close it when we bear down to increase abdominal pressure for childbirth, having a bowel movement, or right before we cough. So we can increase that space or close it when we're bearing down. Okay, so then we get down into the lungs themselves. So we have this model. If you want to grab one of those models from the side thing there, so everybody has a chance to look at that. Refreshing our memory as far as the membranes. Remember, the lungs are housed in a cavity, so they're in the thoracic cavity, but they have their own special cavity in which there's a membrane that attaches them to the body wall. It's the pleural cavity. So the pleural cavity is the space where we find the lungs. And then we have the membranes over the lungs. Remember the visceral pleura? Where do we find the visceral pleura? There's just one model per table. Where do we find the visceral pleura? On the lung. So it's the membrane that's attached to the lung itself. So if on a lab exam, if there was a pin that said name the membrane attached to the lung, or that covers the lung, then that's visceral pleura. And then that membrane folds back as it reaches the body wall and attaches to the body wall, and we call that layer of the membrane the parietal pleura. So that attaches it to the body wall. And then there's a fluid between there, which is called pleural fluid. And sometimes that space, the pleural space, sometimes that's called the pleural cavity. So you have to be aware of what the question is asking. Are we talking about the cavity where we find the lungs, that's the pleural cavity, or the space between the two membranes, sometimes that's referred to as the pleural cavity. Just like we saw with the heart, the pericardial cavity was the space between the visceral and parietal pleura. So sometimes we use those terms interchangeably between the whole area, pleural cavity, where the lungs are found, or those two membranes, the space in their pleural cavity. Okay, so those are the membranes. Then if we look at just the lung itself, it looks like not an upside down triangle. The heart looked like an upside down triangle, right? Remember the base was at the top and the apex was at the bottom? Now the lungs are like a true triangle. We have the more narrow top portion. This is the apex, and this is the base where it sits on the diaphragm. This muscular sheet of tissue here is the diaphragm. So we've got the base and the apex. And the hilum is the central portion where we see airways and blood vessels entering the lung. So this is the hilum. Now, this is an interesting story in the sense that I had a patient who had lung cancer who said, yeah, they found a mass in my lung, but I'm not sure where it is because one nurse told me it was at the top. Then the doctor's assistant came in and said it was at the bottom. And then the doctor came in and said it was in the middle. So I'm not sure where the tumor is, but I'm curious to know where it is. So I went and looked in the chart and looked at the imaging that they took of the lung, and it said a hilar mass. Hilar mass. So where was it? In the middle, yeah. But now if I didn't know my anatomy and physiology, I would have read that and I would have thought, I don't know what hilar mass means, so I wouldn't be able to answer that question, right? But because I know where the hilum is, and I know the word hilar refers to hilum, I could help that patient understand where her mass was. So apex, hilum, middle portion where the airways and blood vessels enter and exit, and then the base. All right, so then looking at the lungs itself, it's broken up into major sections, and each section has its own airway, and then it branches, and those have their own airway, and we'll talk about that. But the major separations of the lungs that we can see from the outside because of the deep grooves we see on the outside, these are called the lobes. So this is on the bottom of page 26. We can see the left lung here has two lobes, one here, and then the right lung has three lobes. And this front has been taken off so we can see the inside a little bit better. But we can see there's a major separation here, there's a major separation here. So we have 1, 2, 3 lobes on the right. And if we follow the airways coming down, we'll see this major branching of the trachea. There's 3 bronchi, 3 major branches. We'll talk about the airways in a little bit. There's 3 airways here and 2 airways here. So 2 lobes on the left, 3 lobes on the right. And then we also talked about the diaphragm here. So if we look at and zero in on the trachea, going back up here. So we have the larynx we talked about. Then we have the major airway called the trachea. And that is surrounded by C-shaped cartilage. So this is completely cartilage in the front, and then in the back it ends. And it's just soft tissue back there because the esophagus lies behind the trachea. So when we swallow a big bolus of food, the esophagus expands a little bit into the back of the trachea. So we wouldn't want cartilage all the way around the trachea because that esophagus couldn't expand into the back side. So, but normally the esophagus is flat because we're not breathing when we're swallowing. So when we swallow, it bulges into the trachea, but not a big deal because we're not breathing at that time. So we have these rings of cartilage of the trachea, and then at the bottom of the trachea, right before it divides into the 2 main bronchi, we have a flap of cartilage on the inside, on the lumen of that trachea, that has a lot of sensory receptors. So if we should inhale a little bit of food or water and it hits that special sensitive area, that is called, this is on the top of page 27, the carina. So it's just at the base of the trachea before it divides. So that's called the carina. So if you see a pin down here before the trachea divides to go to each lung, he's looking for the answer is the carina. And maybe you've had this happen to you. Sometimes this happens to me. I'll put a fresh piece of gum in church, and then it really gets the saliva flowing, and you inhale a little bit of that saliva, and it gets right there, right at the bottom of your throat, and you start coughing violently. Do you ever have that or someone drinks a sip of water or soda, right, and it kind of slips down, and then you start coughing and turning red, and you have to excuse yourself because you can't stop that violent response? That's the airway's last-ditch effort to protect those lungs from getting something non-sterile down in there, because we're not supposed to have food or water or saliva entering those lower airways. So that's a kind of a safety response from the body to get us coughing. And sometimes when you do that, you can actually feel with that violent cough, you can feel that piece of food or whatever kind of come up. That's an important response. So that's the carina. And what we often see is people enter from the nursing home, come into the hospital very commonly with what's called aspiration pneumonia, which is when they're eating or drinking in the cafeteria and the nurse's aide is helping them. If every time you help your resident drink something or eat, maybe take a bite of soup, it's a little more liquid, and they start coughing like that afterward, what is that telling you? What? It's getting to that spot. Yeah. And if it's getting to that spot, most likely it's going beyond there. And they're going to end up with infection in the lungs because of their own saliva or food or drink getting down in there. So if ever, as a nurse's aide or a caretaker of a relative or friend, you see coughing every time they eat or drink, you need to tell somebody. They need a swallow study, and they might need to adjust their diet to thicker liquids. Sometimes we add little powders to liquids to thicken them up a little bit to control the swallowing. Or even there's certain techniques you can use when you're feeding that patient to get them to swallow more effectively. And one is to sit upright, never have someone leaning back where you're pouring a liquid with their pills right down, they're going to cough. So you have them sit up and you have them tuck their chin down to their chest and you have them swallow. They can have better control that way when the chin is down versus the chin being up. So just some things to think about. So that carina really tells us good information if they're coughing, that they've got a swallowing issue, and someone needs to be aware of that. So then it branches. So the first branch of the trachea, if you look on page 27, those are called the primary bronchi. So a primary bronchus serves each lung. So on the right side of the page, on page 27, you've got what it serves. So you have the structure and then the region it serves. So the primary bronchus, if you follow that across to the other side, it serves one lung. So we have two primary bronchi. And then remember, we talked about there's 3 lobes to the lung. So that's the secondary bronchus. So if I look at this main bronchus here, it branches 1, 2, 3. So these would be the secondary bronchi, these branches, these 3 branches here on the right, the 2 branches on the left, still cartilage, right, around those. Those are the secondary bronchi. They serve each lobe. And then those lobes are broken down into segments, multiple segments. And each segment is served by a tertiary bronchi. So all of these colorful branches of the secondary bronchi, those are all called tertiary bronchi, and they serve the different segments, bronchopulmonary segments of the lung. So each little division of the lungs has its own blood supply and its own airway, which is really efficient, right? Because if one part gets plugged or infected or cancerous and shuts down, the rest of the lungs are somewhat protected because they have their own airway, their own blood supply. This special model here that shows the bronchopulmonary segments. So you can see the different colors on this model. It's got brown and green and yellow and pink and orange. These are all representing bronchopulmonary segments. So if you look at on a lab exam question, if you see a colorful portion within a lobe, the answer is bronchopulmonary segment. And then we have this model here too that shows the trachea, the 2 primary bronchi that have the cartilage, and the smooth white branches are the secondary bronchi, and then the black tips on the ends of this model, those are the tertiary bronchi serving the different bronchopulmonary segments. So look for this model representing bronchopulmonary segments. So there are more branches within a lung. Then we get down into the microscopic anatomy of the lung, and that is best shown in your textbook. These are the alveoli. So when we look at these secondary bronchi, tertiary bronchi, they branch another 22 times into smaller and smaller airways till we get down to these tiniest of airways, which are the bronchioles. So here is a bronchiole. It's only surrounded by smooth muscle. So we see that smooth muscle wrapped around the bronchiole. And then we get to the final part of the airways. This is where gas exchange occurs. It looks kind of like a honeycomb appearance, but these are small air sacs formed by simple squamous epithelium. These small little sacs for gas exchange are called alveoli. So the emphasis is on the E. Alveoli is how we say that. So they form these circular structures. So this one's been cut so we can see the inside, but there's the circular structures. And these are wrapped around with extensions. Here's the pulmonary artery branching into these tiny capillaries that wrap around the alveoli, and this is where gas exchange occurs. So oxygen will leave the alveoli, because when we inhale, we bring oxygen into the alveoli, leaves the alveoli, enters the blood here into these capillaries. And then that oxygenated blood is carried back to the heart, to the pulmonary veins. Remember, veins go to the heart, arteries away. So this will branch and become the pulmonary veins and go back to the left atrium. So these are the pulmonary capillaries here that wrap around the alveoli. So there's an alveolar duct, which is simply just a passageway through the middle of the alveoli, serving and branching off into individual little air sacs. So alveolar duct and then individual alveoli. And this would be called an alveolar sac because it's made up of multiple alveoli. So if we look at some of the microscopic anatomy, looking through the microscope slides of this tissue, remember the alveoli we said are simple squamous epithelium. So if I take a cross section and slice these lungs like they're sliced here and make a thin slide, I can see the simple squamous epithelium. So this is an alveolus, this is an alveolus, this is an alveolus, and then where I see just a common passageway, but I see only simple squamous epithelium here, this is an alveolar duct, where the passageway for that air leads to the alveoli. So you could be asked, name this, from what organ was this taken? If you see all simple squamous epithelium, then you know that's the lung. The organ is the lung. If he says, we name this tissue, then we're looking at simple squamous epithelium. Or we could ask, name the structure, specific structure at the arrow, which is where the pointer is, then it would be alveolus. Or if it's in this region where there's not a simple, it's not surrounded by tissue, but it's more of a passageway, then it's alveolar duct. So this is the lung microscopic view of that tissue. Here's another view of the lung. We can see all the alveoli here, all these little round circular structures of simple squamous epithelium. Here would be what? What would we call this passageway here? Yep, alveolar duct. But then it gets thicker here because there's that smooth muscle layer, which is here, being stained on this slide. So what are these thicker passageways called? Bronchioles. Yep. So bronchioles are the tiniest of airways that lead to the alveoli. So these are the bronchioles. So again, the organ is the lung, the tissue is simple squamous, specific structures are alveolar duct, alveoli, bronchiole where it gets thicker here, and here's another cross section of a bronchiole. Then we get to the other tissue you need to know, and this is the trachea. The trachea, going back up, remember, is this structure here, or going even further, We're looking at this structure here. So we know that the outside of the trachea has these cartilage rings. That's hyaline cartilage. So if we go back down to our slide here, the hyaline cartilage is here. Remember the fisheye soup? So that's the hyaline cartilage on the outside. So we're working our way from the outside in. So we have the hyaline cartilage. And then if I look at the innermost layer, there's an epithelium here, and here's where the air would be, is here. So it's the inside of the trachea. I can see there's cilia. Can you see those short hair-like projections there? The cilia help to trap, well, there's mucus lying along that inner layer, and the cilia beat the mucus toward the digestive tract. So when we're collecting mucus on our trachea, every now and then we feel the urge to go like that, right? So when we do that, we move the mucus upward toward the esophagus, and then we swallow that down. And then in the back of our nasal cavity, we have cilia that beat backward toward the back of the nasopharynx, and we feel that collect on the back of our throat, and then we swallow that down. And that keeps our mucus directed in the direction it needs to go, which is the digestive tract, because the mucus is helpful in helping food move through our digestive tract. But it serves a protective mechanism in the airways to trap airborne debris so it doesn't end up in our lungs. So the job of the cilia is just to beat that mucus in the direction of the digestive tract. So we have the ciliated epithelial tissue, and it has a special name because it looks like it's stratified because it's so jammed together, but if you look, the nuclei are all settled on the bottom. And it looks like it's stratified, but it's not. So that's why it's called pseudo-stratified. Pseudo means fake or artificial. So pseudo-stratified means looking like it's stratified, but it's really not. But it has cilia. So the first name starts with ciliated, pseudo-stratified, and these are tall, thin cells, so they are columnar. So it's ciliated, pseudo-stratified, columnar epithelium. That's what lines our airways. Chronic exposure to debris in the air or cigarette smoking damages the cilia. So the cilia are not efficient at moving mucus anymore. So what happens to the debris and the mucus over time in a smoker that has less functional cilia in their airways? Smokers cough because that mucus, instead of being beat upward toward the digestive tract, it continues downward and settles in the lower airways and the lungs, and then people have this nasty cough all the time. So we damage this tissue with chronic exposure to cigarette smoke. So then scattered among these cells, you see these little egg-shaped cells that are circled and highlighted number 4. Those pale egg-shaped cells are called goblet cells, and goblet cells secrete mucus. So they're interspersed among the pseudostratified columnar epithelium to produce mucus. So when we're sick and we have a bad respiratory infection, maybe we're not eating well, we tend to get a little dehydrated, and our mucus as a result of that is supposed to be mostly water. It becomes very thick and sticky. So then if it becomes thick and sticky, can it move well and be beat by the cilia to clear and be coughed up, even if it should end up in the airways? No. So we really encourage people, you hear people with a cold, oh, make sure you drink plenty of fluids, right? Everybody says that. Well, why do we need to drink plenty of fluids? And the reason is to keep our secretions, this mucus that we're producing a lot of during a cold, to keep those secretions thin and movable. So with your patients that have bad coughs and bad lungs and junky coughs that are thick and productive, keep pushing the fluids on those patients as long as they don't have heart failure. Keep pushing the fluids so they can keep those secretions thin and get that mucus to be coughed up and cleared. All right, any questions on the microscopic anatomy of the lung?
What's number 3?
Number 3, you don't have to know. That's in that submucosal layer. That's a good question. Looks like a duct of some kind. I'd have to look that up. We don't teach that layer, so I'd have to look. Good question. But the inner layer you need to know, ciliated, pseudostratified columnar epithelium, the goblet cells amongst them, and then the hyaline cartilage down below. And then again, this organ, if he asks, name the organ this tissue was taken from, what's the organ? Trachea. All right, that concludes the lab on the respiratory system.